Good morning. My name is Janice Mason, and welcome to our next presentation. It's titled Out with Audits, Using Innovative Real-Time Tools to Extract Data and Improve Clinical Care. This talk will be co-led by Krista Cato and Dr. Craig Futterman. Krista Cato is an experienced pediatric critical care nurse leader with over 10 years of experience in clinical care, program management, and nursing leadership. Krista holds a Bachelor of Science in Nursing degree and a Master's of Science in Healthcare Administration. In her leadership role at Children's National, Krista, as nurse manager, supported and collaborated with all disciplines to advance outcomes around quality and safety. In her current role as clinical program coordinator, Krista provides expertise and direct preparedness efforts in areas such as infectious disease management, emergency response, and global health to help advance pertinent issues in child health locally, nationally, and internationally. Dr. Craig Futterman is an intensivist in the cardiac ICU. He received his education and training at George Washington University, Virginia Medical School, Children's Hospital Medical Center of Akron, New England Medical Center, Tufts, and Children's Hospital of Boston. He is certified in pediatrics, anesthesia, and critical care medicine. Dr. Futterman is also a director in the Innovation Center of the Bayer Institute. He is responsible for the development and implementation of a number of improvements in information technology, including a program for communicating with outside and referring physicians, the quality dashboards, and the new code sheet program. Please join me in welcoming Krista Cato and Dr. Craig Futterman.
Thank you. It's a pleasure to be here today to speak with you on nursing research and quality. I'm excited to have Dr. Futterman here. He was an integral part of the project and that we worked on closely in the PICU. The title of our presentation really summarizes a lot of what we're trying to do today. But with any good presentation, it's nice to have a few objectives so you know what you're going to leave with. We really want you to have a better understanding by the end of the presentation about the use of an electronic dashboard and really how it can be integrated in your practice. Also be able to have a conversation with somebody else about how data can be interpreted and begin thinking about how you can apply it in your setting and use it on a daily basis and incorporate it into daily tasks. I want to give a little history, though. So in 2001, as many of you know, the Institute of Medicine Committee on Quality and Healthcare in the U.S. really released a landmark statement titled "To Err is Human, Building a Safer Health System." I think this charged and outlined strategies and new standards for government, organizations, and really the healthcare industry to make patient safety a priority. A few years later, in 2008, we began to see really the impact of this. And public reporting became elevated in the healthcare sector, and quality initiatives became increasingly transparent. In 2010, subsequently, with the enactment of the Affordable Care Act, organizations were now incentivized differently for quality outcomes, and I think we all became aware that the system and structure of healthcare was changing. The reality of professional accountability to an enlightened public really can't be ignored any longer. Healthcare organizations are really increasingly focused on patient safety and quality because they are markers of improvement and success. Our consumers are smarter, and transparency is the new business model in healthcare, especially in the face of internet and accessibility of information and new knowledge. So as clinicians, I think we have a responsibility to ask ourselves, are we really delivering quality care? Can we define what quality of care is? Do we know how we're measured? Do we really know our strengths? And do we know our shortfalls? I think in the face of magnet redesignation, we probably can say, yes, we know elements of each of these questions, but there's still an opportunity. Is this knowledge and information readily available and understood with the frontline care providers and our administrators on the 5th floor, West Wing, able to speak to specific data points within the PICU or CSU on a micro level. I really honestly believe that when there are metrics, we really know if we're delivering quality care. And through metrics, it's the only way we can determine our deficiencies and make them non-existent. So we really have a responsibility to assess if standards of care are being followed, and then do something about it if they're not.
All right, so we're just going to keep going back and forth.
Yeah.
So the concept of big data is something that we all need to understand. There's a philosophical thing about it, and then there's the real thing about big data. So big data is not about the data, but it's really in how you analyze it. This, I think, is a great quote. It says, information is the oil of the 21st century, and analytics is the combustion engine. So whether you're in toy sales or oil in terms of drilling and supplying, or you're in medicine, we're all getting a ton of data, but are we doing anything with it? And in medicine, we're doing a lot less with the data that we're collecting than almost all of industry outside of medicine. And you can have a lot of data without information, but you cannot have information without data, which is a very important point. And we need to learn how to look at the data, how to collect the data. And the question that Anne asked at the end of the last session was, how do we really truly collect in an automated fashion the data and then analyze it? Because we shouldn't be hand-picking the data out of the medical record anymore. So Children's National has 5 terabytes of data. So that's 5 divided by, or followed by 12 zeros, and that's a lot of data. So the National Library of Medicine has a couple hundred terabytes of data. Okay, so we've got a huge amount of data, and we're increasing that by 1/10 of a terabyte every month, or 100 gigabytes a month, or if you think about it, about a terabyte a year, and that number is going to continue to grow. Now that we're automating and we just put online the outpatient record, that data is going to start coming in as well. So we've got a boatload of data, but what are we doing with the data? Beyond everyday use of looking at the chart, yeah, yesterday his vancomycin level was this. We're not really doing much with it. We're collecting it, but that's all we're doing. So going back to you, sorry.
So with that being said, how many of you, by show of hands, have completed an audit? Many of you. How many of you really, by show of hands again, felt that the outcomes of those audits you had the control to fix? Nobody. Wow. We actually all have the ability and capacity to have an impact on the data that we're collecting. But I know it's challenging because we're faced with a lot of data collection. How many of you felt that with the show of hands that you were checking a box and not really having an impact? I think it's easy to feel that way because there's so much data. We collect it, we send it off to somebody, it gets analyzed, and then it comes back to us, and we're supposed to do something with it. I think, though, we have to stand up and acknowledge that we do have the ability to have an impact. And anytime we're asked to do a data, we need to take an element of responsibility to do something with it. So we should think about how data is collected. In the PICU, I'm going to give you a few examples. We collect a lot of data. Some of it's provided to us by the results of surveys that are done within the organization. We track nurse satisfaction and patient satisfaction. And any element that comes back below benchmark, we as leaders and providers have a responsibility to do something about it, plan an intervention. Here are another set of metrics that we really collect, and this is really focused on PICU clinical indicators. These are 4 clinical indicators. The previous slide showed 6 questions that we focused on nurse satisfaction, and 4 questions that we primarily focused on for patient satisfaction. But we know the Press-Ganey survey that goes out to families is about 60-plus questions, so there's an enormous amount of information that we're not really even, I'm not in the PICU, taking a full amount of responsibility to make change for. And then there's additional. We're a part of lots of engagement networks. The Hustle Engagement Network, the HEN network, really means that Children's is a part of a group of hospitals, 36 other hospitals, looking at how to improve outcomes in regards to patient safety, specifically around these 9 initiatives. I won't read them all, but really what that means is when you're part of something and you're looking at how to improve safety, you have to collect some data to have a baseline and know where you're going. The nice thing about this network, though, is they've already done some of the legwork. They've looked at what they feel is effective, and they said, organizations, we believe that bundle compliance is effective in improving patient outcomes. So if you teach your staff about doing these 5 pieces towards something, it ultimately should improve patient outcomes. So go teach your staff based on best practice, collect the data, send it to us, or you guys interpret it, and then do something about it. So this is an example of information that was collected manually through our manual audit. It started manual, and you'll hear more about it later with Amber and Annie Rose's presentation. Started manual, though, on a piece of paper, and this is 1 out of 9. We do this audit. And then as managers, we're responsible for the left side. This is an action plan that we have to create based on these interventions, and this requires manually reviewing charts, patient medical record numbers, extracting information, putting it on a piece of paper, or entering it into another database. And this is for 1 indicator. There's 5 fields that actually have to be looked at. This is another audit that they do, and I want to talk about, audits are important. We look at unintended extubations, and patients in the PICU, sometimes they're on ventilators, and they have airways, and there are indicators that you follow to improve outcomes. So you want to make sure that the tube's in place, that it's in the right position, that it's documented, that it's taped securely. And we audit that. We go to the bedside and we look at all of those factors. And the reason we do that is because it ends up resulting in patient harm if some of those things haven't been done. Patients have received chest compressions as a result of airway loss. So it is important, but it's time-consuming and arduous. I'm belaboring the point, but I think you all get it. In the PICU, we do over 40 audits a month. At one point, it was 100 pieces of paper. We were looking at nurse-sensitive indicators focused on magnet, hospital key drivers, which are important, performance improvement with the hospital engagement network, and the other elements that we all know about. And really regulatory. We have a responsibility for patient safety and maintaining a level of regulatory standards, which are equally important, and safety. They go hand in hand. We know the goal of the audit is actually to improve patient care, but it's hard because there's an enormous amount of data. Evidence indicates that audits, goal sheets, and checklists really are effective in decreasing length of stay, reducing medical errors, and improving compliance with hospital policies. However, they have a limited impact. They underrepresent the nature of the ICU specifically in care delivery, and they only focus on a moment in time.
So continuing on the big data theme, on the inpatient service, nurses, physicians, respiratory therapists go about their day. Very little analysis of the data being collected is done, and it has achieved little effect on their minute-to-minute activities. So if you think about it, if you're a bedside nurse or physician or therapist, does all the data that we have in this medical record affect what you're doing on a moment-to-moment basis? And the answer is no, not really. So we're trying to come up with ways of doing that and asking the questions, how can we improve our, I'm going to use the term behavior, but not in a negative way. We use the term behavior in that how we go about doing our job and getting the things done in a timely fashion. We all know that nurses have been asked to do more and more things. More and more things are put on their shoulders, and it's almost like an unfunded mandate. We've asked them to do things, but not given them the tools to do these things, whether it's reminders to get things done or easier ways to get it into the medical record. So some early warning about some of the things that we have to do can be very helpful. And one thing, and I'm going to show you in a study that was published, that doctors, nurses, and respiratory therapists are very much subject to peer pressure. Go ahead.
And a lot of that comes from peers and then a little bit of pressure from the managers. Yeah. Managers are challenged because we have all this data, and to Craig's point, we are expected to do something with it and make it meaningful. And our responsibility is to identify solutions for staff so they can receive information. It's clear, and it's up to date. But when you have 100 pieces of paper, it's really hard to give it back to the staff in a timely manner, and make it clear. And you can see on the right, this is something we did in the PICU. We're trying to show them one element of information and put some interventions with it and show what's been effective. But you can see there's inconsistent formats and data representation, and it makes it really hard to interpret.
Okay, so the study I mentioned, this is a study out of Iowa, and they looked at the effect of peer pressure and does it improve hand washing adherence amongst healthcare workers. And instead of going through the whole study, I'm just going to give you a conclusion or two, and it says that the presence and proximity of other healthcare workers is associated with higher hand hygiene rates. And that's hard to say. Furthermore, their results also indicate that the rates increase as the social environment becomes more crowded, but with diminishing marginal returns. So if you have one person working in isolation and they're not being watched by other people, and I'm not talking about secret shoppers, but I'm talking about just coworkers, they're not going to wash their hands as much as if they were being watched by other people. And that's called human nature. It is. I mean, we have to, we all like to think that as healthcare workers, we're kind of above everybody else from that standpoint, but we're not. We're people. We're normal people, and we're subject to the normal emotions and attitudes and vicissitudes of our job. So we have human flaws. We're subject to peer pressure, and they had hypothesized that having a dashboard where everyone could see everybody else's work accomplishments, it would push people to get their job done well.
We also believed, and I think this comic says it all, we also believed that good management information systems were essential for the appraisal of quality care. We live in an age where technology is really how people work. You ask somebody younger, we'll say in their in their 20s, to use a computer, and you hand them a mouse, they're going to look at you like, what is this? The mouse is out. This is the same thing. The teacher told us to bring a pencil to class tomorrow. What's a pencil? We need to use the tools that we have at hand.
I just got used to using a mouse. Oh, my God.
It's out. So this kind of speaks to our project. In conjunction with the Center for Pediatric Informatics, a panel of providers came together with this theory that we could extract data from the electronic medical record that focused on quality and safety and somehow put it up on a TV screen for everybody to see. We believe the presence of real-time visible safety and quality information systems could reduce the burden of audits, allow for staff performance assessment, and actually improve patient outcomes. And that's our team.
Power Rangers.
So our team met it felt like weekly, and maybe more often sometimes, met a lot over 2 months, debated. We did an audit of actually who had good ideas and bad ideas, really discussed what we felt was important and what we wanted to track, and we ended up with agreeing on 9 best practices for the incorporation of this dashboard. They focused on really the Joint Commission quality standards and safety, and over 14 months, Craig's team, designed, built, tested, and then implemented this web-based integrated platform. And then I'm going to go over this, but this is small. You don't need to read it. Just listen. Really what we felt was these 9 best practices we could extract from the dashboard, make it visible, and somebody could actually do something about it real time, in the moment, the care providers. So consent was one of them. Really how it worked was these are initiatives that are supposed to trigger a response, and then on the TV you'd see there's non-compliance. So consent's a good one. Consent. So anybody that didn't have a consent or didn't document there was a consent in the medical record, on the screen it would have the patient's room and say, hey, there's something wrong here, and then the provider could go in and say, hey, there's no consent. So it would trigger an alarm to say there's no consent, and I'll show you that in a minute. This was important to me for a few reasons. In the PICU, what we used to do every day was we used to have our UCA, initially when we weren't electronic, go to every single bedside to see if we had a consent. And those that didn't have a consent, she'd say to the nurse, hey, you don't have a consent. And then the nurses would say to the physicians 2 hours later around, hey, I need a consent. And then one physician would say, hey, you need to follow up with that family. And then 4 hours to 6 hours later, you might have a consent. It went to electronic, and so then the UCA changed her process, and she went to the bedside nurse and said, do you have a consent in the computer? So it didn't eliminate all of this time that was wasted when we could be focusing on doing something else. And consents are important, not just from a regulatory perspective, but from a safety perspective for the clinician, the organization, and the providers. In addition to the patient, it lets them know that they've been informed about some of their rights. That's why consent was important to us. Restraints, the same thing. You don't want to have somebody in restraints without an order. And you don't want to be documenting on restraints without an order. Urinary Foley catheters. This is huge. And personally, this was a big one because in the PICU, we were struggling. We had UTIs. We needed to analyze it. We had all this data. But really what we found, every time we had a UTI, we'd meet as a group. We'd have an RCA. We'd drill down. We'd put up with this action plan based on best practice. Really what we found was that our patients had unnecessary Foleys, and Foleys were in too long. So we wanted it to trigger when a patient had a Foley. And it started at 96 hours, and we reduced it to 48 because we thought it was more meaningful and allowed us an opportunity to evaluate if it was needed and then remove it if it wasn't. So just something simple where somebody didn't have to go do all this deep data mining. DVT prophylaxis was big. We had some kids with clots, and we kept looking at, what are we doing? Well, kids are getting bigger at a younger age, and we need a visual reminder when not every patient's 12, and it's not a standard practice for every patient. It's hard to remember. So we wanted this to prompt people, you're missing something. Not just nurses, but physicians. They have a huge element of responsibility here.
You do.
So Braden Q was big. That was another indicator that we struggled with. Hospital-acquired condition is pressure ulcers. We want to do whatever we can to reduce hospital-acquired conditions. So we thought we could alarm and alert people if a patient had a Braden Q of less than a certain number. We needed to pay more attention day one out the gate, so the second somebody recognized the kid was high risk. MedRec, same thing. You really want med reconciliation to be right. Why do you want it? It's regulatory. It's safety. I think it's really clear why it's so important. You want to know what medications a child takes at home so you can reinitiate them post-operatively and so you don't miss anything and have an untoward outcome. WAT scores, for those of you that aren't in the ICU, are something that really it's a withdrawal assessment tool, and kids in the ICU are often sedated, given sedation, and then we wean it quickly. And some of them go into withdrawal, and it's painful. It creates increased length of stay. And it's important, and we have an opportunity to wrap our hands around it and do something if we know that they're withdrawing. So we thought if a nurse charts this number, we want to be triggered because it means that physicians and nurses have a responsibility to be aware of it and have a conversation. Pews, when we started this, I don't know, from my perspective as a nurse, I thought it would be really cool to have the information because the PICU charge nurses respond to cats. And that's what it is. High pews triggers a cat. And so I wanted, in the back of my mind, to track how many cats were we going to, and thought this would be a great way to extract that data. I think the physicians wanted it for a different reason. And then Neuro detailed, it deserves its own slide. So I don't know how many of you know Nathan Dean, but he's like the Neuro nerd. Yeah, totally. Within the PICU, and he sat in on a meeting. He's like, we have to have this, and then he created this big long criteria of all the things that if any of these things were flagged in the medical record, we'd be alerted about a patient that we needed to pay attention to. And really how I look at this is, on this TV, if you've got that little Neuro symbol, you've got an issue, because it really means that something is going on that needs immediate attention, and you're at imminent risk.
Let me check something right here. So just to give you an idea as to how all of this works, the programs we developed, first of all, when we decide to do these dashboards, there are only two limits as to what can be on the dashboard. One, it must be in the EMR. If it's not in the EMR, it can't be on the dashboard. And number two, it's your imagination's limit. That was it. And so these are and we also have a limit of number of things that can go up on the screen. But so the computer is constantly doing a search for all the patients in our census, and it refreshes the board every 5 minutes, so that if you make a change in your documentation, that documentation shows up in 5 minutes or less on the dashboard. So for the Neuro one, it looks on any patient to see if they've got an ICP monitor in. And if they do, it looks to see if there's a blood gas that has a PCO2 of either less than 25 or greater than 40. It looks at pupillary size documentation, and you can see what it looks for. Or if the Glasgow Coma score is less than 7 and they're not on certain kinds of medications. So they're not the simplest of algorithms, but they're not terribly complex either. And it works, and it works well.
And here is phase 1, and that's pretty much what you're seeing. This is phase 1. So we were the first unit in-house to have a dashboard. And so being the first, in theory, it's supposed to mean that you're the best. But really, we all know that when you implement something the first time around, typically somebody comes behind you and creates something better. So this was phase 1, and really that's what it shows you, is it has the consent, and then it would just pull the patients through.
Yeah, so you can see that a particular room, we couldn't just list all the rooms because in the PICU you have 44 beds, not enough to fit on a 50-inch screen. But so if anybody needs medication reconciliation, those are the rooms. And hypothetically, the docs look at that in the morning and they go, get those done. And then they get done. ICU consent, go get that consent done because, Krista was talking about the UCA having to look in the charts and then looking in the EMR. And we know it takes a long time to log into Cerner and all that other stuff. And so this is always up there. And so you're saving a tremendous amount of time extracting data and rather than taking all that time to do something about the data that you see. And this is what the early version looked like. Go ahead.
Phase 1. And so part of it, though, one of the biggest things that I wanted was to be able to provide something that was real time. And so this was a component that we have on it. Early, it looked like this. And it has the current census, and it tells the staff if they're looking at it when it was refreshed. So everybody knows what's real time and what they have the ability to impact. And then in addition, we wanted a counter. We wanted staff to know how long it had been, how successful we had been over a period of time in not having any hospital-acquired conditions. And then we also wanted to promote and engage in some dialogue. If somebody thought it's been 5 days since the last BSI, somebody should be looking at that and saying, hey, Craig, what happened? What'd you guys miss? So real-time data that could be used to highlight success and talk about opportunities.
And we just blame it on the nurses.
And we blame it on the docs.
So this is the redesign of the dashboard. And what we did was the first dashboard was developed before the Bear Institute. So myself and some programmers started designing all of this stuff, and we actually wrote the programs and put it up, and that was our first one. But once the Bear Institute came along in the Innovation Center, they have some wonderful people you met so well. Some of you who were here at the previous talk an hour ago, Kapil Nair, who was sitting on the end over there, is the director of the Bear Institute. And he and I and Ian Crumbly and a few of the programmers sat down and decided that we're going to create a framework for which all the dashboards can be utilized. And there are basically two kinds of frameworks. One is the larger units like the PICU, 7 East, the NICU, where they have so many you can't fit it all in one dashboard. So we chart everything by exception. And then the other ones like the CICU and some of the other smaller units will have all the patients are listed and there'll be check marks or red X's, which you'll see in a moment. But we also came up with these little icons. We had the docs and the nurses sit down and they had a choice of icons. And so, medication reconciliation with a pill, Foley catheter. It really is a glass of juice, but it looks like urine. So it's you can look at what the problem is, or you can look at it by room number. So room 304A has 2 issues. 321A has 3 issues, and those need to be resolved, either by the nurses or the docs.
So I really thought it was a tool that everybody could use and apply into their daily workflow. When we first rolled it out, though, we quickly realized that we needed to have spent a little bit more time on education and re-education, because ultimately we want this to be something that the staff can use and they can realize that, hey, this is helping me. It's really not creating more work. So I want to share just a few applications of how we've used it in the PICU. So the PICU charge nurse, Christy Pomeroy, has really pioneered this for us as a shift coordinator within the PICU. And I sat down with her and I said, hey, how do you use it? I've seen it used, and I've seen everybody use it a little differently. But she talked about how she used it in her practice. Every time she was on, this is what she did. So she standardized what she did to help the staff really get buy-in. So we do our morning huddle every day. So at morning huddle, she'd highlight the patients at risk. And so the patients at risk for her were the ones that actually had the brain, so neuro detailed, a Foley. She'd raise awareness, hey, this kid does a Foley, and make sure you do have a discussion around if it's really needed or not. And then ET2, because the last thing you wanted to do was send somebody on a road trip where there's some discrepancy between what's ordered and what's documented. And so it really empowers the nurse or the staff or anybody to know what's wrong and have a conversation. PCT huddle, we also do this PCT huddle, and we use the dashboard with our techs because we want them to be a part of the care plan. And so she talked about Foleys, patients that had Foleys. So anybody that had Foleys, they should be at the bedside talking to the nurse. When are you going to do Foley care? Do you want me to come help? Anybody that had a high or low brain NICU, really, that tech should be talking to the nurse and saying, hey, when do you want me to come and help you turn your patient? Do you even need help? So we use it to empower the techs to get involved in care, and they could just look at that and know what was needed, but we also incorporated it in our huddles. MD night, we do this cool night huddle where all the physicians sit around at a table in the PICU with the charge nurse, and they talk about all the kids that are sick. So we use this dashboard really to look up and be like, hey, we're missing some consent. There's still some med recs. And then we talk about pews. We're always interested in what's going on the floor because we care. We really do care. And then the crisis nurses, Kristen shared with me, she said, the crisis nurses increasingly are coming in. They're looking at the pews up on the dashboard, and then they're going out on the floor and they're having a conversation with the nurses to say, hey, and then either mentoring them or kind of raising a level of alarm within the PICU so we know that we might get this kid or there's something that can be done. Yeah, right. Yeah. And then the PICU nurses. So I already talked about huddle, but really what they could do is when they see their assignment, and I use this as an example, this is a nurse that's paired. She has 321 and 323. This nurse can look up and realize immediately what items she needs to have a conversation with the off-going nurse, what items she needs to mention in rounds, and then what follow-up needs to occur with the respiratory therapist, because this kid's missing a consent, something med rec needs to occur, DVT prophylaxis isn't in place, and then something's going on with the ET2 that needs to be addressed. So it allows her to look up, walk in, look up, see what's up, and know what conversation she needs to have without ever looking at the patient's chart. And then respiratory therapy, you want to share a story to really drive this home?
So we have this both in the PICU and in the CSU on our dashboards. And when this says ET2 is an issue, what we do is just the normal routine. When we intubate a patient, we get our x-ray, we make sure it's in the proper position on the x-ray, and then we document where it is on this end, either at the nair or the gums or the teeth. And in the order, it said it should be at, say, 12 centimeters at the gum. Okay. Once a shift, the respiratory therapist goes through and documents where he or she measures it actually is. And if they're the same, great. But if they're different, it shows up. And how is that important? The day after we put up the dashboard in the CSU, in the CSU for our single ventricle newborns, we always try to get an MRI of the brain before they go to the OR. And so it was one evening, we were getting ready to send a small intubated baby to MRI, and I noticed that on the CSU board it said the number was in red. It's a little bit different presentation on the CSU board, but it said there was a mismatch. And I said, stop. The nurse was already leaving the room. They were not happy with me. I said, stop, go back in the room, let's get an x-ray. And it turns out the tip of the tube was like way up here about to come out. And sending this small child intubated into the worst environment you can send anybody, which is MRI, we potentially saved either an accidental extubation or a disaster. Okay? And so this is just a reminder. Hey, check on this kid. And it's big data helping us without us even asking for it.
And I think it makes it clear there's a million ways the physicians could apply it into their role. And I've circled everything that the physicians need to follow up on based on this dashboard. So I want to take this opportunity to highlight some of the work and how it could actually be applied in research. So Angie Collins submitted an abstract for Research Week. It was accepted, and she did a poster. We just found out was a finalist, so you can see her poster in the atrium, and I'm excited about it. But she really used the dashboard to help her in reducing catheter-associated urinary tract infections. I'm not going to share all the elements of the study, but really she was promoting nurse-directed surveillance and the impact of urinary catheter removal, and it leading to a reduction in urinary tract infections. When we first started tracking urinary tract infections, she used to twice a week go through every single patient's chart to see if there was an order for a Foley, to see the insertion date, to then count the number of days it had been in, and then go to the bedside to actually assess if it was needed. So what she was able to do with and this picture's small, and I'm not going into the meat of the dashboard because Ian's going to be presenting later a lot of the technical aspects, and you can learn more through him. But what she was able to do was pull up in a list view. It's the same dashboard, but a different view, a list view. All the patients that had Foleys, and then if you hover over it, it'll tell you the date it was inserted, the Foley day, and so she could glean more information and didn't necessarily have to go through all the charts anymore. She could now just go directly to the bedside and have a conversation because we're really focused on a nurse-driven criteria for early removal.
How much time did that save?
Enormous hours, seriously hours, especially when the census is high. So I'm proud of her. She implemented in her project, and as a result, we have excellent data and have had a reduction in urinary catheter tract infections.
So speaking of that, when we started this dashboard project, Brian Jacobs, who is an intensivist and probably everybody knows the Chief Medical Information Officer, suggested that we should study this, see if it really this is really cool whiz-bang technology, but does it make a difference? And that's an important question that everybody should ask every time somebody introduces new technology to you. Does it make a difference? How do you know? So we actually studied this. So Annie Shaw, some of you may know, was a fellow, critical care fellow here. And she was the primary author on this study. We launched the dashboard, but didn't put the data up on the screen for a month. Then we turned it on. And I will tell you that one mistake that we did make was that we didn't show from a leadership standpoint, both physician and nursing, that this was very important, that the nurses really needed to pay attention to this. And we didn't show by example or by mandate. Fine. So we really ended up taking the data from the third month, not the first month after it went up. And we had 450 patients in the analysis, and between the two time period measures, mean time between PICU admission and consent for treatment decreased by 49%. P is less than 0.05, so it's statistically significant. The percentage of catheters in place for greater than 96 hours, remember what Krista said, initially we had 96 hours as the warning time, was decreased from 11 to 4%. Again, statistically significant. And completion of MedRec, which has been a very important thing, increased significantly from 80 to 93%. Yeah. So for all the other parameters we had up there was no real statistical difference in time. But there were three meaningful outcomes with this. So we wrote the paper and submitted it to the Joint Commission Journal on Quality and Patient Safety, and it has been accepted for publication. And so we're very happy about that. The NICU Dashboard, you want to talk about?
I'm just quickly going to show you one or two of the other dashboards because it can be applied, in almost any setting. But so the NICU is like the PICU. They have too many beds to have that list view and see everything. So it has to be in this view by exception. And their priorities are set based on really what they are. You can see some of these are different. I think they have breast milk on here. Obviously the PICU doesn't have breast milk, but that's something they track closely. The CSU Dashboard is awesome. They have just the right amount of patients to be able to look at them all and immediately know what's missing. It's up and running, and they're integrating it, and I'm excited because soon they're reconstructing it on the back end. Soon they're going to extract additional data for some of those hen audits. They'll need to do less of it, and they'll be speaking later on this afternoon, so I don't want to steal their thunder either.
But in the CSU, what we do now, we just started this a couple of weeks ago, is we do a safety huddle. So before we start rounds in the morning, the entire team meets in front of the dashboard with the charge nurse, and we go over a bunch of things that aren't on the dashboard, like admissions and what's our census, what our nurse staffing is, and who are patients that we really need to be worried about. And then we go to the dashboard and we say, there's, like, for instance, this 7.5 right up here. That means that the endotracheal tube order distance and placement measurement are two different things. So we point that out so that it's a higher priority. We got a few red X's on chlorhexidine baths. And it's been nearly impossible to get everything out of the red. Although 2 nights ago, Jen Schutte texted me a picture of the dashboard. There was no red on it at all. And she goes, "We are badass," you know. So we can do this. And what it tells me, too, is that people are beginning to take it seriously. And that's the biggest issue, is we've got to learn as leaders to use the dashboard ourselves, both physician and nursing leaders, and impress upon the nurses how it can be helpful to them and their patients, okay? And by the way, these dashboards all can be brought up in Cerner itself. There's a tab, and you can just bring the dashboard up, and you can even sort it by name and room number and that kind of stuff. So we have, I mentioned before, we have the fixed set of frameworks. We have software modules, and what I'm encouraging now is, like, HEMONC is, anybody here from HEMONC? Okay, so I sat down with some of the leaders, Rose and Jeff Dome and a few others of the docs on HEMONC, and said, it's your turn. And I said, the limitation here is your imagination and what's in the EMR. But I want you to come up with more parameters than you can put on the dashboard. Because there are going to be some parameters that are like, why are we doing this? It's always perfect. That doesn't need to be up there. So we can literally, from a software standpoint, unplug one parameter and plug the other one in. So that's the value of this framework. We're putting them on 50-inch monitors, although those are getting expensive to install. So what I was thinking about is short throw projectors, so not that far away, but literally like that, and putting them on a blank wall and adding Google Chromecast to it, and that way it just comes over the Wi-Fi right on there. So it's a lot cheaper to install, and you do an LED bulb in the last 2.5 years, that kind of thing. But all of those things are very helpful. 7 East has their dashboards running, but there's nothing on the walls right now. And, of course, it's all about dollars.
And additionally, I mean, it's a great tool. It can be used, but it really could be used when the magnet appraisers come. If you have a dashboard, bring them over. Talk about what you're doing. It's an opportunity to raise awareness about the clinical indicators. We have literally about 2 minutes left, so we're going to skip through a few slides, but I want to really summarize towards the end some of the lessons learned. It's really important early on that you involve everyone in your decision making. Look at the data that you're collecting and think about how you can make it meaningful. Look at what's in the medical record and see how you can reduce the burden of audit. Talk about roles and responsibilities before going live. That was a big thing. We had this great project, but nobody knew what they were supposed to do once we went live. So delineate that. And just remember, the data is really only as good as the documentation. So if the documentation is poor, this isn't going to be the best tool. You have to fix that first, or at least raise awareness. This can make workload so much better. You can focus on, actually patient outcomes. So really with the application of the CSU Dashboard, we were able to reduce the number of audits completed, hands down. We were able to show a positive association between using visible real-time dashboard displaying compliance and patient safety with quality measures to improve some of our patient outcomes. Not all, but some. But we were the first, and now we can learn from the rest. Real-time information technology can be incorporated into daily workflow to improve patient care on a day-to-day basis, real time. So I'm back to what we started with, out with audits. Use innovation to extract data and real-time patient outcomes. On the right is kind of still where we live a little bit. We're doing these manual things. We have a ton of information. Use it. Allow it for real-time synthesis. The days of manual audit should be coming to a close. And use innovation to help you. Think big. And I think that the biggest thing is think big. Follow the ANA model. This is the ANA model here, but I added a few. Engage staff and integrate innovation. So I added to their model. And then think about how this could be used to highlight your successes and engage your staff.
And so this really is just, the dashboard is just really the tip of the iceberg. Think about this as a bedside nurse or as a physician or a respiratory therapist. We have disease X. Let me check, how have we treated disease X the last 30 times? Boom, it should be able to come right up, okay? Or I have these 4 signs that I see in this patient. How many patients have had those 4 signs, and what did their diagnoses turn out to be? Why can't that automatically come up? This is 2015, and I'll just tell a small anecdote. My wife is an MBA and worked for IBM for 25 years. And 10, 15 years ago, I was talking about, hey, we're going to get ready to go paperless, or we're going to do this. And she laughed at me. She says, Craig, you're so far behind the rest of industry, okay? And my personal feeling, and there's probably nobody here that could affect this, but, you know, Children's, 2 years ago, I know the numbers, 2 years ago, Children's had an annual budget of $1 billion, and 5% was spent on IT, $50 million. $50 million is a boatload of money. It's not enough because we're not using our technology the way we should and the way we could. Nurses are being asked to do more and more and more, including the documentation. And one nurse said to me the other night, would you rather me take care of the patient or document it? Okay? So one of the limits to documentation is how fast it takes to log into this daggone system, right? Now, hopefully with the new badge swiping system with the VDI interfaces, that's going to be better. I know that when it got launched in the 70s, it was difficult. They had challenges. I'm told it's better. I don't know. But you know, we have a lot of red X's, not because it's not getting done, because the nurses batch their documentation because it takes too long. So we need to solve that as well. But like I said, this is the tip of the iceberg. We should be much further advanced than we currently are. And now I'll shut up.
So this really concludes our presentation. I want you to be able to have a break, but we're happy to answer any questions in between the break that you might have and stay for a few minutes. Really, I just want to acknowledge I've done something.
Escape.
All right. So here's our references, but I'm not going to read these. But
you got all the references?
Yeah. They're there if you need them, and I'm happy to share. But really special thanks to this list of people, because this wouldn't have been possible without their support. Although I'm no longer the manager of the PICU, it really is a collaborative effort, and we continue to look at ways to improve patient care and outcomes in the PICU by using innovation technology. Thank you.
Any questions? Yes. And you can still get up and go.
Yeah, thank you. It's a very exciting lecture. It was a lot of fun, too, which is always great. So one of my questions is your feedback loop to your providers. So you've got good feedback in that you can go see, you know, your metrics of looking at when these things got done in terms of your targets. But as I'm a provider who's showing up on that board a lot for not doing my consents, is there a feedback loop to providers? Like, would I stand out to you and you'd say, hey, you know, it's you always on the board?
That depends on the managers of the particular units, because we don't identify who's responsible on the dashboard. I'm not sure we have a way of knowing in every case. So that would depend on the managers.
So for the PICU, the consents are a big one. And I think because we have residents, it makes it an interesting dichotomy. So it's harder to streamline the consent element. But for all of the other indicators, if, you know, Foley catheters and some documentation for restraints, the nursing elements are easier to provide feedback on, and it's something we track. But some of the physician components, because I don't manage physicians, is more challenging. I mean, I do, but they don't know it.
Yeah, that's right. It is much more challenging.
I think that's great. The only other question I had is, did you do a lot of Cerner enhancement forms as you were doing this dashboard in your data collection fields related to, you know, the bundles and different things? Did you start to find, like, wow, there's a reason why we're not getting this done because there's some enhancements that need to be done?
No, we didn't look at the Cerner enhancement forms at all. Although we did when we were wanting to put Pews up, that became a real roadblock because Pews is hard to enter into the medical record. And I know that Ian Crumbly, who's going to be talking to you later, I'm told, is that right?
Yes.
Ian, who has been really our lead person on this, and he's a nurse as well as a geek. And so that really is a good combination because he did ICU nursing. So he knows from both ends. He's working on a better way to do Pews. In fact, there are 3 different efforts. One is what's going on here Philips monitoring folks, if we're supposed to upgrade our Philips monitors next year, they have a thing, and then Cerner has their own, in Cerner Math, which is another division of Cerner, that they want to be able to do something like that. So things like that, yeah, I think that it's very difficult for us to enter data into Cerner, and that's one of the next steps. Problem is we're limited by $50 million budget, and that sounds like a lot of money, but it's not.
I'd like to thank you all. That fantastic, absolutely, work going on and presentation. But we do want to stop, so if you have pressing questions, and I have one, so don't go away, but we need to make sure that we stay on schedule and give people a little bit of a break.
You did really well.